Does this sound familiar? And does this look familiar? These pictures, which were taken in our facility, represent an epidemic hitting healthcare workers nationwide. This epidemic? Alarm fatigue. Since 2005, more than 216 patient deaths have been directly attributed to alarm fatigue. In 2007, a 77-year-old patient was admitted to a telemetry unit. Alarms for low battery went unanswered. This patient had a cardiac arrest that went unmonitored and subsequently died. In 2011, the Pennsylvania Safety Authority reported that over a 6-year period, 31 of 35 reported deaths related to physiologic monitoring were attributed to human error, 28 of which involved a telemetry monitor. That's 28 deaths directly related to human error with a telemetry monitor here in Pennsylvania. Wow. So wait, what's alarm fatigue? Alarm fatigue, by definition, is the exposure to an excessive amount of alarms resulting in sensory overload. This leads to alarm desensitization, which is a delayed response to alarms, possibly even no response at all. Healthcare workers report more than 350 alarms per patient day resulting from the monitor itself. But are all of these alarms true alarms? And is there such thing as a false alarm on a cardiac monitor? Yes, a false alarm is an alarm detected by the monitoring system which indicates a physiologic event when no real event has occurred. Examples of what causes false alarms include patient motion, poor electrode placement, and poor electrode connection. There is such thing as actionable and non-actionable alarms. Non-actionable are true and valid alarms that do not require clinical intervention or are the result of intentional alarms. Examples of this are heart rate, whether it's bradycardic or tachycardic, and PVC amounts. Separating actionable from non-actionable alarms requires critical thinking about your patients. Of course, actionable alarms require timely intervention to avoid an adverse event. Nuisance alarms, such as those that are non-actionable and false, represent 95% of alarms that do not require clinical intervention. This could be why we are not as attentive and reactionary with cardiac alarms, even though, as we all know, alarms are meant to draw attention and save lives. But instead, alarm fatigue is causing us to react less, which puts our patients in danger. Alarm fatigue has serious complications, which can include cardiac arrest and possibly death. Next, you might ask, what's being done about it? And actually, a lot. The Joint Commission on Accreditation of Healthcare Organizations, otherwise known as JCAHO, has created a patient safety goal for clinical alarms. There are 2 phases in this safety goal, one of which requires hospitals to establish alarm safety as a priority and create a method to managing alarms by July of 2014. Well, that's 3 months ago. The second phase involves creating policies around supporting alarm management. The American Association of Critical Care Nurses also created a practice alert. These alert hospital teams of the need for change. The practice alert for alarm management was created with numerous amounts of tools and education useful for staff. So what can we do here at St. Luke's Anderson campus? Our hospital supervisor group spent 4 days collecting baseline data on telemetry alarms here on MedSurg 3. Let's take a look at what we found. In this data collection, 57 patients' alarms were reviewed on 4 separate collection sessions. As you can see, we found a total of 1,838 alarms. Of these, 1,046 are true, 752 were false, and 40 ST alarms were found. The ST alarms were not considered true or false as there are too many unknown variables, and education was needed to determine the accuracy. This graph shows that of the 1,046 true alarms, 8% were considered actionable, while 92% were considered non-actionable. Let's review the definition. Non-actionable alarms are true and valid alarms that do not require clinical intervention or are the result of intentional alarms. Examples of these are heart rate and PBC amounts. In this graph, the total alarm count is broken into actionable and non-actionable alarms. Non-actionable in this graph includes all false alarms and non-actionable true alarms, which total is 95% of the total alarms. Separating actionable from non-actionable alarms requires critical thinking about your patients. Actionable alarms requires timely intervention to avoid an adverse event. Now that we have shown why a performance improvement project in alarm management is needed, we will present our plan and how we hope to reduce alarm fatigue. We are going to use the infamous plan, do, check, act cycle and recheck alarm rate after our education to determine if the changes are successful. Our goal is to reduce the total alarm rate by 10% in 2 weeks. Our plan is to educate staff on ms3 on electrode etiquette with this video. We also plan to review how to manage and customize alarms with the nurses on our cardiac monitor after this video. Our hope is that using proper electrode etiquette and improving the nurses' alarm management and customization skills will both reduce our alarm rate. We will then recollect data 2 weeks after the education is completed. So let's start by reviewing electrode etiquette. Did anyone know that this is actually part of our telemetry policy? Our policy supports what is also found in research, which is using a 2x2 gauze pad to debride the skin prior to applying each telemetry sticker.
My name's Anne. This is Nicole. We'll be your aides. Today, we're just going to put the cardiac monitor on you, okay?
We are wiping your skin with this small piece of gauze to allow a better connection for our monitor. By doing this, we are hoping to get the best picture of your heart rhythm on the monitor.
Notice how Nicole is using the 2x2 gauze to debride the skin before Anne applies each electrode. This here is known as proper electrode etiquette.
There you go. All right.
Thank you.
If excess hair is present on the patient's chest, clipping is the best method of removal. Pictured here is a set of clippers which can be found in the med room and the blade which can be found in the clean utility room. Washing the skin with soap and water is the best method for cleaning the skin if it appears dirty or oily. Research does not support the use of alcohol wipes on the chest. Alcohol cannot come into contact with the gel on the electrode as per manufacturer's recommendation. Proper skin preparation decreases skin impedance and signal noise. We have covered a lot in this short video. Let's review. Proper electrode etiquette includes removing hair with clippers if necessary, washing the skin with soap and water if necessary, and using 2x2 gauze to wipe the skin on each patient prior to placing each electrode patch. When do we start, you may ask? We'll start now. All patients admitted or transferred to ms3 must have telemetry stickers removed, use of proper electrode etiquette, and a new electrode applied. Thank you for attending this session. Let's work together as a team to reduce alarm rates and overcome alarm fatigue.